How many parts will we have?
This will be the last part, I hope. I'm sorry, I'm really hungry.
That's okay.
And then we start part 1 again of something else.
What's there?
Oh, you're eating.
What is that?
Chicken.
Fried chicken. What are the others?
Broccoli and capsicum.
What's the little?
You know how you do your chronic disease, right? Yeah.
And
One of the
then
treatments that the person.
that looks like rice.
There wasn't much rice there.
Huh?
There wasn't much rice, so there's not that much rice there. There's like a tablespoon all in one corner.
Okay. Cool.
Okay.
Choose any of them. Yeah.
Hello everyone. Welcome again. I promise this is the last part, but I promise today is going to be fantastic. We're going to go through lots of different things. It's going to be evidence-based. It's always evidence-based, but this week especially so. Okay, and okay. Oh, whoops. Okay, anyway, okay. So let's start. So this is our first question. Don't worry about it.
Okay, so what's the question actually asked? Like, what's the diagnosis?
Yes, probably.
Yeah. So 6 months ago. Oops. So 6 months ago, we have a relatively young woman, and she had early pregnancy loss requiring a DNC. Since then, her periods have been very scant. So it also says at the top, what's the most appropriate option? What do you think? Do you think it's Mullerian agenesis? No.
No.
This one, PCOS, anorexia, POF. This one, which one? What is it? It's Asherman's. Okay. So what is Asherman's? So this is a picture of a uterus, okay, not a fortune cookie. This is a uterus. So the lining of the uterus is lined by endometrium, right? So this is endometrium, and this lining is composed of two things. So if we were to look at it histologically, this is what we would see. Well, not this diagram particularly, but the endothelium is broken down into two components. Okay, so we have the functional layer and we have the basal layer. Now, who knows which one is closer to the which one's closer to the surface? Yeah. So the functional layer is important because this is what is shed during the actual menstrual process. So the basal layer is what is located closer to the endometrium, and that is not shed. So what happened? And the basal layer is important to allow regeneration of that functional layer. So what happens in something like Asherman syndrome? Often you have it after you have a DNC. So DNC is when you're scraping out the uterus essentially. And what can happen is you can have damage to the basal layer. And having damage to the basal layer can cause intrauterine scars resulting in adhesions. All right. So this is just histology of how it actually looks like. So this is the myometrium, which is just composed of smooth muscle. And this is the endometrium. And what you can see, you can sort of appreciate how there's two layers there. Right? You have this highly glandular layer, and glands, if you remember from first year, are lined by columnar epithelium, yeah, because that is what's secretory. And then this one is less glandular. So this is the functional layer, and this is the basal layer. So you can see that here. So these little squiggly things, all of these are uterine glands. And if we have a look at this previous picture, this is the uterine gland, okay? And this is the spiral artery, and that's what's important to know. So the uterine gland is important for secreting mucus type substances and as such that it helps to maintain the pregnancy and the fetus. So it's very important. So the reason I show you this is because it has relevance to this. So this little picture on the side, this picture that I'm pointing at here, this is the normal progression of the endometrium during your menstrual cycle. So M stands for menstruation, P stands for proliferative, S stands for secretory, and then down here would be your premenstrual phase. So the importance of putting this here is you can notice how the uterine glands, they progressively get longer and they steadily grow as you progress through your menstrual cycle. And what maintains that uterine glands, or what maintains that endometrium, is progesterone. And as you slowly get through your menstrual cycle, as the corpus luteum starts to break up and you get less progesterone, then you have menstruation occurring. So I just put that in there just to help you potentially maybe understand the menstrual cycle a little bit better. And the importance of progesterone as well. Okay. So this is a video. How do I get it to start? Give me 1 second. It's easier to draw.
Maybe just bring up the detail.
How do I play it?
Openly or copy and paste information.
Make sure that you chose it correctly. Your forecasting thing.
Yeah, I hope so. So this is just a picture. So this is a hysteroscopy, right? So they're coming into the uterus here, and just watch. So first, what do you notice there? What do you think that is? Do you think that's a branch tract? That's an adhesion, okay? So that's what they mean by intrauterine scars and adhesions. So you can see here, this is why they call it adhesiolysis. So lysis means breaking down. So breaking down of the adhesion. So she's going to break down the adhesion here. You see how she's breaking it down? So that's Asherman syndrome. So that's not how a normal uterus should look like at the start. So that's why she's breaking it down there. So that is why the procedure is called uterine adhesiolysis. And you do that using a hysteroscopic approach.
Do you risk creating more adhesions?
I mean, with any surgery you do, but but the thing is that you can understand by that video that it's quite severe, that her uterus is literally like that.
So
And
you're
with
hoping that you're cutting back enough that like it makes more of a difference.
yeah, and I mean the thing is that you have to understand, like I was talking about before, Asherman syndrome is because you have damage to that basal layer. When you're doing adhesiolysis like this, there's less risk of that kind of damage because you're not like scraping the endometrium.
Yeah.
Right. So the only reason I included that video there was so that I can get a copyright strike, and also hopefully to help you to understand a little bit more about the syndrome. Okay, I need to just check if the stream is still working.
Yeah, it is.
Okay. Yes.
Can I go back to the previous question? So which of the two phases was it that is variable, and which one's the one that's same regardless of how?
So I think what you're referring to, but I'm not sure. The LH surge always happens 2 weeks after menstruation.
Okay. So
That's something that's set. Everything else can be variable.
Yeah.
Okay.
Okay.
Next question. Okay, so we have nulliparous woman. Oh, whoops. What does nulliparous mean? Good. 38 weeks, spontaneous labor for 8 hours. Is that normal? Yes, that's normal. Okay, fetal heart rate has been monitored during the first stage with intermittent auscultation, has been reassuring. She had pethidine. Is that normal? Yes.
Not
Is it?
anymore.
Yeah, so both are very good answers. So opioids are still used, morphine more than pethidine, and we're going to talk about this, so I'm not going to go into it now, but it's still unusual that she's on pethidine. Okay, 3 hours ago, when her cervix was 6 centimeters dilated, well, that's kind of reasonable actually. At that stage to give pethidine is okay. So going on and on. So she's bowel pressure, pushing involuntary, +1 station, full dilation, good cervix, baby is in a good position, so right occipital transverse. So we know what that means.
It's not the best position, but
It's an okay position. Okay, so during the vaginal examination, the fetal heart rate drops to 60 beats per minute for 3 minutes. What will be your initial management? So tell me what's going through your head right now. What do we call this? What would be a presenting complaint? What do we call this?
fetal distress during
Oops.
labor.
Sure. Okay. So fetal distress, and what particularly is happening? What's the pathology?
Fetal hypoxia.
Okay. Well, we can't know for sure, but what I'm trying to get is that baby is bradycardic. Okay. So bradycardia. What do we do? What should we do? Should we use Neville Barnes? What's Neville Barnes used for? Instrumental, but so there's a few things that we can use for instrumental. What's Neville Barnes particularly for? When the baby has a face presentation or they don't have a proper presentation, then we'd use Neville Barnes. Okay, rotational.
That's Achilles is the rotational.
Sorry, Neville Barnes. You can't. Okay, something about Neville. Okay, we'll go on to that. Something about face presentation. Okay. Anyway, all right. Both of them instrumental. Continue with CTG.
You're hoping that the baby's gonna recover.
Okay. Emergency C-section. No. Wait for the fetal heart to recover spontaneously. Okay. Move to a left lateral position and attach a CTG.
Is that unreasonable?
Intramuscular symptometrin / oxytocin. What would we use that for? Yep, first line. Encourage pushing and await spontaneous vaginal birth. If we did that, what would we risk? Yeah, okay. Low ventrous birth.
That's the.
No, I'm saying what are we
Hypoxic escape.
Okay.
Okay. So low ventrous birth, no. Elevation to McRoberts? No. Commence IV oxytocin, no. So what do you guys think the answer is?
Too soon.
Okay, so we have, I'll give you a few options, okay? So we'll put, okay, I won't put a circle around it. I'll put rotational. I'll put continue to auscultate, recover spontaneously, move to left lateral, and encourage pushing. Okay, put your hand up for B, and everybody has to vote. No, because we're going to run out of time otherwise. Put your hand up for B. Okay, put your hand up for C. Be confident. It's okay to make it, to show what you believe in. Anyone for C? Anyone for E? Anyone for F? Anyone for H? Okay. Okay, that's correct. That's good. Okay. So I told you it would be evidence-based, okay? So using the King Edward Memorial Hospital WA guidelines, because I couldn't find Victorian guidelines, but despite that, most people will follow the same kind of technique. For any situation where you have suspected, so suspected or recognized, it doesn't matter if the baby is actually compromised or not. Even if it's suspected, these are the steps that you follow. And I've summarized it just for you guys, okay? So 1, call for help and inform your seniors. So seniors in this situation refers to calling the obstetrics registrar and telling them what the situation is. It doesn't mean that they need to come down right now, but you have to tell them what the situation is and that this baby has been bradycardic for 3 minutes. Okay, then you have to have an arrow. Then the next one, you have to apply the CTG monitor. Now in that question, CTG by itself wasn't an option. Okay, so apply CTG. Next option is get IV access and get a group and hold. So plus minus group and hold. So it depends if the situation calls for you requiring group and hold, so you don't always need it. And the IV access is important, and we'll talk about why it's important soon. And then the next one is identify any reversible causes. So what does this mean? What does that mean? What does a reversible cause mean? Position? Okay, but what about the position is bad? Okay, so you can have cord compression from the position. You could have pressure on the baby from the position. I guess the position is important. What else is important? What's another reversible cause?
Dehydration.
So dehydration in who? Okay, mom, and what does that cause? Maternal hypotension. So maternal hypotension is something that can be reversed, and that is why we need to get IV access, because we give them an IV fluid bolus. Okay, what is another reversible cause? Anybody? Yeah, that's reasonable. Yeah, reasonable. Okay. Okay, we'll just leave it there. Okay, so maternal position, hypotension. Okay, IV fluids is IV fluids. Stop oxygen. So if they're on an oxytocin infusion, that's something that can cause uterine hyperstimulation syndrome. This is another thing that you need to identify. And if they have too much uterine contractions, then you need to give them trocholysis. Okay, so these are the reversible causes that we need to try and identify. So in any situation where you have fetal bradycardia, okay, so any situation where you have fetal bradycardia, this is what you need to do. So 1, you need to reposition the mom. So reposition. You need to give them a bolus, so bolus fluid through the IV. You need to stop, so cease the oxytocin infusion. So cease oxytocin. You need to check the BP. Okay. You need to check the pulse. Now, why do we need to check the pulse? There's a very logical reason for this. Yes, exactly. So the reason you check the pulse is because you want to make sure that you're not actually measuring the maternal pulse versus the baby's pulse. And that is a really important point, because that was actually a question on the past exam where they had a fetal heart rate. It was like 97 or something, and the answer was maternal heart rate. So it's important to identify. Okay. Last one is you need to do a VE. Now, what are we trying to identify on the VE? Cord prolapse, okay? Now, if there is cord prolapse, what are we going to do? What was it? Good. Don't remove your hand. That's really the point I'm trying to get across. Why? Because we're trying to decrease tension on the cord. Okay. All right. And then, the other thing is, so in any situation where you have a CTG abnormality, you always have to consider whether you want to do a fetal scalp electrodes. Okay. And number 8 would be query C-section / instrumental. All right. And then the last one, yeah, there you go. So that's just important to remember. That's where I got it from if you want to search it up. And it'd be a good idea to just have a read of that document. So the answer to this question is change the mom's position. That's the first thing that you should do. It's a very easy reversible cause that you can identify. All right. So going on from the previous question, fetal heart rate remained at 60 beats per minute for a further 2 minutes. What would your management be? Just give me some options. So are you concerned?
Starting to get concerned.
Yeah? Why are you getting concerned?
Getting too long, and we've tried to reverse the identifiable causes, and yet the fetal heart is still remaining there, which probably means there's something else going on.
That's a very good summary actually. Try to reversible causes. Perfect. So what would you do in this situation? So you followed all of these steps, right? You've informed your seniors, you've done the CTG, you've got that, you've tried all of these. So then the next step in this pathway is consider further fetal evaluation / birth. Now, none of the options here say none of these options have a fetal scalp electrode. So we can rule that out. So we need to consider whether we need to give birth or not. Do you think that's a reasonable option?
Yeah.
How are we going to deliver the baby? So there's a few options here. We have Neville Barnes, we have rotational, we have a C-section, we have a ventouse, we have normal pushing, and oxytocin of 1 unit per hour. Okay. So what would you choose? Would you choose a Neville Barnes? No. Would you choose a Keelan's 4-step birth?
Maybe.
Maybe. Why do you say no, Pusha? Is that +1?
Yeah, it's a +1.
Goes that way.
Yeah. Okay.
6 centimeters away.
It was fully dilated.
I thought it was 6 centimeters.
No, that was the start.
That was the start.
Ah, okay.
Okay, I'll write that here. So she's fully dilated, and she's at +1 station. I should say the baby is.
And
Okay.
transversus.
All right. How about, we'll just pull that up. Low ventouse. Oh, sorry, emergency C-section. You choosing that? Okay. Emergency C. Okay. Yeah. Why not? So okay, we can rule out the rest. So it's either emergency C-section or instrumental, right? These are our emergency ways that we can get a baby out. Put your hand up if you think the answer is instrumental. So ventouse birth is another way that it's another instrumental type of delivery, but it's not very commonly used. And I'm not sure what the indications are either. Okay. Put your hands up if you think the answer is Keelan's. Okay. Put your hands up if you think it's an emergency C-section. Roland, what do you think?
I don't know.
Nicole? All right. So I want to tell you about the journey I went on to find the answer for this question, okay? This took me a good 30 to 40 minutes of my time to get an evidence-based answer for you guys. Okay. All right. So I wanted to find out, first of all, out of a C-section and forceps, what the actual correct answer was. So first, I looked up fetal compromise guidelines, and that didn't really help me. So then I looked up fetal bradycardia guidelines, and again, that didn't help me. So then I thought, how am I going to get the answer for this question? So then I looked up forceps indications and contraindications, and C-sections and contraindications and indications, and finally, I struck gold. Okay, so let's go through some of the things that I found. Now, the first thing, so the question that we need to ask ourselves, is the baby compromised, and do we need to do something about it? The answer to the first question is definitely, okay? So prolonged bradycardia, so less than 100 for 5 minutes, are likely to be associated with significant fetal compromise. So that's from the previous guidelines that I told you about, the King Edward Memorial Hospital WA guidelines. So we answered the first question. So then the second was, if we wanted to do a C-section, or I guess is, do we need to do a C-section? And the answer to that question is yes, okay? So less than 70 a minute for more than 3 minutes is an indication for doing a C-section. Greater than or equal to 3, and it has. So it's...
So what about the previous question?
Hey.
No, that was, okay, we'll talk, there's still more, okay? There's still more to come, okay? Okay, hold your horses, okay. So look, this evidence, and this is from Ranscog, urgent C-section recommendations or something of that nature. So this only helped me to answer, can we do a C-section? The answer to that was yes, but it didn't tell me forceps or C-section. Okay, so then I went to search more, and I found this. So this is, again, from Ranscog, and this is the Ranscog document about instrumental delivery. And what it tells us is that a cesarean section with a fetal head deep in the pelvis has significant side effects or adverse effects. So those include tears in the lower uterus, hemorrhage, and urinary tract injury. But yet, this still does not definitively tell me what the answer is. So I kept on searching until I finally found this little gem. So this gem, this is from, I'm pretty sure, it's all here. So I found this. So this is from like a physician's resource from ARCOG about different things. So, and when I read this, I thought this is actually really logical. Why did I not think of this? So doing a C-section when the baby's head is already descended into the pelvis is one, as we talked about, risky. And second thing, you can't or you shouldn't do a C-section during the second stage of labor anyway, okay? So for those reasons, it's clearly, well, it's not necessarily, it's a relative contraindication in this situation to do an emergency C-section, and you need to do an instrumental instead, okay? So that's why you do a Keelan's forceps, and all of the requirements for forceps are already met. And one of the indications for forceps is fetal compromise. So remember we talked about last week so we talked about the 5 indications. So then mnemonic was 5, but there was actually only 4. So it's like fetal compromise, then something else, and something else, and a lot of other things that you should remember, but I don't have to. Okay, so we'll just read through this. So instrumental vaginal deliveries have the potential for harm for the mother. Okay, maybe it wasn't that one. There you go. So a second stage cesarean section is not a substitute for instrumental vaginal deliveries, as it can be extremely difficult to perform and is associated with high morbidity and implications for future births. So the answer to this question definitively is instrumental.
How do you choose which forceps?
So Neville Barnes, I swear I wrote it down. Let me have a look.
Neville Barnes only for OA.
Neville Barnes, I wrote down Neville Barnes is only for face presentations. So that's why you can't use it. So if the baby has a face presentation, which they didn't, it was right occipital transverse, you can't do a Neville Barnes.
Whenever I was on birth suite, like whenever you do instrumental, they just like can't get to Neville Barnes. Even
Because
if they were like not doing
Is it for AP as well?
Well, you have to use guidelines. And that's the best I could find. And that was from one of these validated documents that I was looking for. Okay? Yes, to my understanding, but please look it up. If there's confusion, I don't know. Look that up as well. Okay? So I don't know why I didn't think of doing this sooner, because I always look up guidelines and documents. But from now on, I'll try and include a box like this so that when you go home, you can read these guidelines and documents yourself. Okay? So the answer to that question was...
I mean, that makes sense. You can always try instrumental first, then go back to cesarean later.
Yeah. That's a very good point that you make, because these patients are going to be, well, let's look at this here, okay? So these patients are going to be transferred to theater anyway. So when they're in theater, you do a trial of forceps, and if the trial of forceps fails, then you could potentially move on to do a C-section. But again, as we talked about, it's going to be risky given the baby is in that position.
I think I actually saw a patient that had that same situation. The kid had a pulse, face pulse, pushing the body afterwards, because they have to push it back up.
Oh, yeah. Yes, it can be terrible. Okay, so it took me a long time to actually find an evidence base for where this rule came from, but I finally found one. So if you go to the ARCOG, so down here, ARCOG CTG interpretation document, you'll find the rule of threes. And the rule of threes is a really good way to help you out in OSCEs, okay? So if the baby has bradycardia for more than 3 minutes, call for help, okay? 6 minutes, move to theater. 9 minutes, prepare for an assisted delivery. and then aim to deliver the baby. So in this, so I guess, well, you know how one of the options from that list was wait for the heart rate to come back to normal, okay? So that's something in theater, you might reasonably be able to do that, okay? But you have to remember that you're not just twiddling your thumbs in that situation. You're getting all of your equipment ready. Your theater nurses are getting the patient prepped. You're getting all of your equipment onto the field. So there's still lots of things that you're doing in that situation. And I've said this in the previous, one of our previous things is that something like 90% of CTGs, even though, or maybe 90 is too high, but quite a significant percent of CTGs that are abnormal, in the end, have a completely normal baby, okay? So just keep that in mind. So this is the rule of threes. So, sorry, not immediate CS, just immediate assisted delivery. Okay, very good. Any questions? Great. Okay, so this continues on from the previous question. So this is the most important sentence here. Okay, so this little, so this 1, 2, 3, 4, 5, 6, 7. So this 7 words, okay, help you to come to a clear diagnosis. What is the diagnosis? Shoulder dystocia. Okay. Have you done women's?
I'm doing.
Okay.
This is really day 5.
Okay. So shoulder dystocia is the most likely.
No, I'm talking about the.
Oh, Akusha is just the one who delivers the baby.
I've been pronouncing it wrong.
The Akusha is the person who delivers the baby. Yeah. So it's,
I've been pronouncing it wrong the whole time.
so
What did you say?
the diagnosis here. So the likely diagnosis here is shoulder dystocia. Okay, we know that because shoulder dystocia is defined as a vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has delivered and gentle traction has failed. So in this situation, gentle traction has failed. Therefore, the likely or the diagnosis that you have to come to is shoulder dystocia. What is the first line for shoulder dystocia? After that, McRoberts.
No, that's after service.
Okay, so we'll talk. So this is a mnemonic. I'm sure most of you probably have heard of this. Helper. Okay.
Help.
What's what's number 1?
Help.
Help. What's number 2? Look. I spent like 15 minutes doing these mad animations because it kept getting messed up.
You're wasting your time.
I know. Episiotomy, if required.
You have to assess.
Whoa.
Whoa.
Oh my god. So legs, so McRoberts maneuvers. Okay. So that's the important statistic right there. It in 90% of people, because it increases the size of the pelvic outlet, or sorry, the birth outlet, it helps to deliver the head of the baby. So that's why it's successful in up to 90% of people.
Why don't they do that in every?
Whoa.
They do. That's why it disturbs. When they have
Then suprapubic pressure. Okay. And then this is the important part. Enter. Did you see how that entered onto the screen?
That's so lame.
Okay. Thank you. Okay. So McRoberts. So for our rotational maneuvers, what comes first? Rubens 1. Okay. So the mother is still in the McRoberts position. That means her feet are up in the stirrups. Okay, and her legs are wide like that, like you would be doing a pap smear for. You're applying downward pressure here. So this is the suprapubic pressure. Okay, and you do this for less than 60 seconds. So that's the important part. You do each of these for between 30 to 60 seconds before you move on to the next procedure. The reason for that is there's a risk of HIE again, of cord prolapse, and there's significant morbidity for the baby the longer that the baby is in shoulder dystocia. Okay, all right, so this is suprapubic pressure. All right, after this is done, what do you do? Rubens 2. So look, these are really good pictures as well. You know where I got these from? These are from the Queensland Ambulance Guidelines for Shoulder Dystocia or something. It's a really good document because I have really good pictures.
How many sponsors did you get for this presentation?
Let's just say that I put a lot of effort to try and get the correct answer for you guys.
We can tell.
Okay, so Rubens 2. So if Rubens 1 fails after 60 seconds, you do this. So you continue the suprapubic pressure, okay? Then fingers of one hand so this is one hand there, is inserted into the vagina, and pressure is applied behind the anterior shoulder, okay? So you're trying to rotate the shoulder out so that you can pull the baby out, because you can see here the shoulder is a little bit stuck, okay? So you might have heard it termed, one second, you might have heard a term like this before, where they say posterior aspect of the anterior shoulder, and you can see it here, right? So this is the anterior shoulder, it's the one that's most in front, okay? And you're putting your hand behind it, so the posterior aspect of the anterior shoulder, and you're trying to rotate the baby.
So pelvis pressure.
Yeah.
What's the difference between superficial pressure and Rubens one?
It's essentially the same.
Okay. So
Yeah,
Skip Rubens one.
it is Rubens one. So suprapubic pressure while the mum is in macrobus position is essentially the description of Rubens one. Okay. And then do Rubens 2. Okay. So as we just talked about, what comes after Rubens 2? Rubens 3. Then.
Is Rubens 2 the same thing as Rubens?
No. Okay. That's why I went to the effort of looking at this document. So the best way to remember it is that there's 1 and 2, and then there's another 1 and 2. So there's Rubens 1, Rubens 2, then there's wood screw 1 and wood screw 2. So wood screw 2 is just reverse wood screw essentially. Okay, so wood screw. So if Rubens 2 fails, you keep, so I'll rub all of that out. See, so your Rubens 2 finger is still there. So you're still in Rubens 2 position. Okay, then you get your other hand, which is here. Okay, which is inserted in front of the posterior shoulder. And what you're trying to do, you can see the arrows there. You're trying to rotate the baby around. Okay, so this finger is pushing in that direction. Okay, while the other finger is pushing in that direction. So that's why it's called a screw, because you're rotating the baby around, much like a wood screw. Okay, so if that fails, then you go on to do the reverse wood screw. Okay, so the reverse wood screw. So I mean, you need to get your, I guess you need a picture in your head to see how any of this works. Okay, so compare it to this picture here. So that's how it was there. And so one finger is behind the anterior shoulder, and the finger is in front of the posterior shoulder. And in this situation, you're just trying to move the posterior shoulder altogether. Okay, so you're trying in the opposite direction. So if the first direction in the wood screw didn't work, then you try to move the baby in the opposite direction by 180 degrees. Okay, and by doing that, you're trying to attempt to deliver the posterior arm of the baby. Okay, so you're not going to remember any of this as I just talk about it to you now. You need to look at these diagrams, maybe look at some videos. The OSCE, the Women's Day where you actually do the emergencies, is actually really helpful, and that's when you'll remember most of it. I don't think you don't need to know any of the descriptions of how to do it, but you need to, the order is important of the helper mnemonic. So Rubens 1, Rubens 2, Woods 1, and Woods 2. Woods 2 I just made up, but it just stands for the reverse wood screw. Okay, so then the last line is, so we're going back to our ER. Actually, help, what was E? Enter. Okay, so we're going back to R. Okay, oh, it's helper, isn't it? So remove the posterior shoulder, which is essentially what you're trying to do with the reverse wood screw, and then you want to roll. So this is when you see the mom on all fours. So I actually saw this being done when there was a private patient who came into I can't say the hospital, I already said it, who came into hospital, right? And they had twin breech delivery, which in any situations you would never allow them to, in the public system, to deliver normally. But she was adamant, and she went through the private system so that she could have a normal delivery. And it actually went on uncomplicated, but she did have to go onto all fours for them to actually deliver the baby properly. So it can work in a lot of situations. So then our last line, if none of this ever works, you can divide the maternal symphysis to try and increase that diameter. You can do a Zavanelli, which I think, as Roland was alluding to before, where you push the baby's head back in, but just like he said, is associated with a lot of morbidity and lots of mortality. It's not something that you want to do. Or you can do a clidotomy. And I'm not actually sure if this order is correct in this 1, 2, 3. I'm not sure if that order is actually correct. But clidotomy is where you break the baby's clavicle and then you deliver it. And I think that is actually done not commonly, but not necessarily uncommonly. Ah, okay. So just as I was reading, as you can tell, I read a lot of things for this. So I was reading some kind of literature, and and it was saying that for shoulder dystocia. So if we go back to that question, right, where the baby, they couldn't deliver the baby's head and they kept doing the traction, right? And that is why we developed all of these soldier dystocia guidelines. Because if you keep putting that traction onto the baby, what do you risk happening? A brachial plexus injury. So a brachial plexus injury is the most common complication to happen after shoulder dystocia. And what I came across from reading this is that so shoulder dystocia is actually the third most litigated obstetric-related complication in the UK. Okay, so the third most litigated obstetric complication is brachial plexus injury from shoulder dystocia. So then I was interested. So well, I'm not sure what the actual procedures are, but I looked at to see if that actually mirrored what happens in Australia. So I went to the litigation documents for what happens in Australia from the 2012 to 2013. From the 2013, and obstetrics also came in third place. I wasn't sure if brachial plexus injury was still the most common, but it's interesting to see nonetheless that obstetricians are by and far one of the most common specialties to get litigated against. Okay, so last question for this set, I believe. So they managed to deliver the baby 1 minute later, so that means the McRoberts probably worked, and the mother has 300 mils of blood loss. Is that okay? Yeah, so what would you give her? So no, why don't we give her IV? That's okay, good. So one unit, first of all, is definitely not enough, and there's no evidence. So there was a 2016 like meta-analysis or something which suggested that there was no significant difference between IM and IV. So IV, IM. Okay, so next question. So we have a 40-year-old. 40-year-old, she's completed her family. She has 3 children, all born vaginally. She has menorrhagia and desires reliable contraception. What would you give her? You give her a vasectomy, right? Okay.
Doesn't even have.
Okay, barriers. Would you give her condoms? What? First of all, what's the main issue here? Menorrhagia. It's not contraception, right? The issue here is menorrhagia. What's first line for menorrhagia? That is not 100% correct. Okay, so it depends on what their actual history is. If they have chronic bleeding, if they have fibroids less than 3 centimeters, and they have no other structural abnormalities, then Mirena is first line. But there's a lot of situations where Mirena isn't necessarily first line, although in clinical practice, Mirena would be used first line. But the answer to this question is yes, Mirena, that's correct. So Mirena is really good, 95% reduction in the blood flow for people who have menorrhagia, so it's really, really good. But if you didn't need contraception, and this is just guidelines based, so this is straight from prompt. So if they didn't need contraception, what would you consider as the first line? Methylenic or tranexamic acid, but if they didn't need contraception. And that's still used, especially in the younger population, but it actually doesn't have as much efficacy as Mirena does. But the reasons that you might use it would be, for example, if it was a younger patient who has a very small cervix, it'd be very traumatic for you to actually insert a Mirena into them. So that's why it'd be reasonable to use methylenic acid or tranexamic acid in that situations. Oh, and the other thing is that NSAIDs, so methylenic acid especially, would be more beneficial than Mirena if they had dysmenorrhea as well as menorrhagia, because it can help with painful periods. Okay.
Still talking about if you want to.
Yeah.
How would you transit them?
Yeah, like we just talked about. So
Combine it with NSAIDs.
yeah. So if you had the best scenario would be you had quite a young patient who had dysmenorrhea plus menorrhagia, who would be inappropriate for Mirena. Methylenic acid, tranexamic acid would be a good first line in that situation. Okay.
Tranexamic acid also has the pain. Okay.
Tranexamic acid and NSAID? I don't know.
I'm not sure.
Tranexamic acid is an NSAID, isn't it?
I'm pretty sure it is.
That's it. Yeah.
Oh, okay. I'm not sure. Okay, sorry, thank you.
I thought it was an NSAID.
Okay.
Tranexamic acid causes clotting.
They're both first line. Maybe they're not NSAIDs. Okay, they're not. Okay, I'm sorry. Okay. All right. So we have a younger female, 18 years old, sexually active in a stable relationship. She has PCOS with oligomenorrhea. But I mean, it's easy for you to say that, but why? Why is the COCP better than something like the Mirena or something else? Other than buzzwords.
It helps with the acne as well. Has anti-androgenic. No, I think there is this anti-androgenic effects.
Only some have anti-androgenic effects.
Which
I was
ones?
given the other ones.
Yes.
Yeah, yes, and what else?
Diane.
Diane, and there's another female name that I forgot.
Yes.
Okay, so this is why. So where is this from? So this is from Gene Hales. So these are from the PCOS guidelines. And what the PCOS guidelines tell you directly. So I can't give you the pathophys, but guidelines say that COCP should be used alone. Okay, very reasonable what you said, Nicole. I imagine that's probably true. You probably couldn't use progesterone alone if they have anovulatory periods, which is the problem. Well, which is often the problem in somebody with PCOS. So keep that in mind. Okay.
Progesterone is protective against endometrial cancer.
Oh, you don't get estrogen. Oh.
Anyway.
Chop, chop.
Whatever. That's cool.
Okay. 20-year-old woman. She wants to have reliable long-term contraception. Quick return to fertility after seizing the contraceptive. Hasn't been pregnant before. Doesn't want tablets. So what would he give her?
Implant
Okay. Well, there's two options, isn't there?
implant and bilateral tubal ligation.
Okay.
Bilateral.
Okay. Implant and what else? Depo. Okay. Implant and depo are your options. Okay. So how do you choose between the both?
Fertility.
Okay. So yes, that's exactly true. And I had to look this up for myself. So this was, what is this? This was a this was a case review, or it was a systematic review of many of the studies that have been done for comparing all of the return to fertilities for many of the contraceptives. So what you see here is implants and injectables. So this is what we're trying to compare. Okay, so we're comparing these two, and what you see is that really the return to fertility is comparable. Okay, now the reason that this is 7.7 months, the reason that number is so high was because there was one study alone that had an abnormally high return to fertility. So if you exclude that study, the return to fertility would have gone down to 4.4 months. Okay, so 4.4. Okay, so what we can see from this study is that it's actually comparable, the return to fertility. However, many other sources still state that depo has up to 6 to 12 months return to fertility. Okay, now the reason that this might not necessarily, I haven't looked into this, I didn't have time to read the whole paper, but the reason that that's not reflected in this table, for example, would be the standard deviation is not reported to us. We don't know how big the population was. So what I'm trying to say is, for example, for depo, there might be quite a few outliers who have a return to fertility that is 12 months. So typically the teaching is that depo has a longer return to fertility, but this study would suggest that it's quite similar.
It makes sense that the Mirena has the best return because it's well, out of those three, because you don't have as much systemic hormone. So why is that not a good option?
Yeah.
Very hard to get it there.
Yeah. So the thing is that in clinical practice, I mean, it would be a consideration, and even the guidelines don't state that it's a contraindication. But for an exam setting, for an OSCE setting, it's something that you need to think about. For a nulliparous cervix, in the Monash setting, it's a relative contraindication to using Mirena.
But also in real world, if you just put in a Mirena, you didn't get as covered by Medicare. So they bill it as a DNC. So they just do a DNC for 1 month.
Yeah, so they also like do it together. They can. Yeah.
Yeah, for,
Cool, I didn't know that. That's awesome.
No, even
I was also contraceptive therapy, so we could only
So the other thing, so there's no clear. I mean, I also think Implanon is the better answer. There's no strong evidence I can give you that it is the best answer. But the other thing you need to remember is that Implanon especially has a higher risk of having irregular menstrual bleeds. And I saw this myself in clinic. So there was a person with a disability who had an Implanon, and they were having irregular bleeding, and that was causing them severe distress. So that's something that you need to think about. Depo has less irregular bleeding or less of the side effects than Implanon does. So that would have definitely been a better option in that kind of scenario. So just keep that in mind. Okay, next one. So this condition may have a reduced incidence by both parents ceasing smoking. Anybody know? SIDS. So that's absolutely correct. So the risk ratio is 2 or above for parents who are smoking. And this is not just smoking in front of the child, smoking during pregnancy. Even after pregnancy, sleeping in the same bed with your baby for a mother who smokes, you don't even have to actively be smoking. Sleeping in the same bed with a smoking mother increases the risk as well. So you can understand how much impact it actually has. So even passive smoking. So with SIDS, so the other thing you need to know is that classically, the teaching was that you get them to sleep on their face, right? You remember, you guys might have heard of that. Okay, but that teaching changed where you told them to get them to sleep on their head. Now, the reason that they initially, that was the recommendation, was because of something called deformational plagiocephaly. You guys probably should have heard of the word plagiocephaly, right? Have you guys heard of it? Okay, well, it's relatively common. So plagiocephaly just refers to the plasticity of the neonatal skull. So when they're sleeping on their head, it can cause a deformity. It can cause their skull to shift in shape. Okay, so that is why the other thing that you need to tell parents or to tell parents to prevent SIDS is not only get them to sleep on the head, but at all other times encourage them to have tummy time. So supervised tummy time. So sleep on their back when they're sleeping, but at all other times be on the tummy to try and decrease the effects of the deformational plagiocephaly. The reason we worry about plagiocephaly is because of something called torticollis. Have you guys heard of torticollis? Yeah, so torticollis is when you have an abnormality of your neck posturing. So that can be something that can be very debilitating and hard to manage later on down the line. Okay, so this condition may have a reduced incidence by taking 0.4 milligrams of folic acid.
I don't know, maybe that, yeah.
Which one? Why? Not close.
Because there was
Evidence-based medicine.
Oh, just like, what am I doing? Are you sure that's the answer? Oh, actually, yes. So, yeah. Sorry, I was thinking about the next question. Okay. How about this one then?
epilepsy.
Why? So do you think the neuronal abnormalities in epilepsy has an effect on the child for causing spina bifida?
No, the anti-epilepsy.
Oh, good. Okay. So the anti-epileptics. Okay. So because of the anticonvulsants or anti-epileptics that are on, this increases the chance. So what are particular medications that are implicated in this? Yeah, valp. So valproate more than 1 gram is important. Okay. Phenytoin, carbamazepine. So carbamazepine. So all of these can cause a deficiency in folic acid by interfering with the way it's absorbed. Okay. So that is why they need to be on a higher dose of 5 milligrams rather than 0.4 milligrams. Okay. Also important is 5 milligrams in anybody who has a family history. So anybody with a family history of a neural tube defect. Say it. Is it? Okay. Hemolytic diseases. Yeah, diabetes for sure. There's a lot of things, but just the other important thing is not just if they're on one medication of these implicated medications, but if they're on more than one. So if they're on more than one anticonvulsant, you also start them on 5 milligrams of folic acid. Okay. How about contraception? What kind of contraceptive advice would you give someone with epilepsy? And we had an epilepsy station last year, by the way. Yep. Okay. So barrier plus COCP. Okay. And the COCP is a 50 milligram dose, by the way. I'm not actually sure what the common dose is because I know there's like a 40 and a 50. Maybe it's 30 and 50, but I know there's 2 doses, but I don't know which one you actually commonly give. But regardless, you give the 50 milligram dose to people with epilepsy. 50. 50. Okay. And to decrease the risk of pregnancy.
And also, CSCP is less effective if they're taking it incorrectly. It's just an interaction.
Okay, so that's very important. So you'd either do 2 or you choose a method that is not affected by the medications that you're on. Okay, not hysterectomy.
So like, will Marina be affected or
No.
not? Okay.
Or something like an IUD, something like Depo. Okay, so what you should tell them, talk to your gynae. Okay.
So is the answer thalassemia?
No, epilepsy.
No, but it says on our talk, thalassemia also gives you 5
It's epilepsy.
Literally look at the search up there now.
No, but thalassemia is not like a strong essential.
Like,
Does it say that you always give it to them? You always give 5 milligrams?
Vitamin supplements should be recommended.
Because if, for example, thalassemia, he could be talking about thalassemia trait, or could be talking about alpha or beta thal, or thalassemia minor. There's many different thals. Whereas epilepsy, nearly always you're going to give them 5 milligrams. This is true. All of this is true. What does it say about thalassemia?
In terms of what? Like, you can just bring it up on the screen. Just beta thal, rather than alcohol.
We'll do that later. Look it up at home, folks. Okay. I'm sorry, Roland, but thank you for bringing it up. Okay, next one. So these are all relatively straightforward questions. So progesterone side effect, volume, stasis, pelvic pressure, muscle relaxation of veins. What is it? Varicose veins. Okay. Next one. Usually resolves early in the second trimester. More common in multiple pregnancies and molar pregnancies is hyperemesis. Okay. And that's because hyperemesis is completely hormone related. That's why molar pregnancy is associated with severe hyperemesis. Okay. So too much muscle relaxation in the GIT, improved by fluids and fiber. This is just giving you the answer. Constipation. Yeah, this is the 2013 exam. All right. Most commonly used inhaled analgesic, short half-life, nitrous.
That would work.
Okay.
Just bonked him out.
So after administration, this analgesic may cause a drop in BP, leading to bradycardia on the CTG. Yes, epidural. And for everybody here, we're going to be talking about analgesia very soon. Okay, next one. So administration of this intramuscular analgesic close to the time of delivery. Why do they even have to put intramuscular? I feel like that analgesic close to the time of delivery may cause respiratory depression in the newborn. Pethidine. What else here is intramuscular? That's per oral. Okay, that's in the, oh, that's IV. That's oral. That is just giving you the answer. Well, I guess water injections. No, actually, no. Water injection is subcutaneous.
Water injections.
Yeah, it is. It's into the back. Okay. So electrodes, TENS. This is okay. All right. So we're going to be talking about the different types of analgesia that you can use in labor. All of these are important and essential for you guys to know because you could very reasonably be in the counseling station for a patient who asks you about labor advice and pain advice during labor. So you need to know all of these. Okay. So this is directly from the RANSCOG guidelines, also from the Y-Files, wink, wink. Okay. All right. So natural ways that you can relieve pain in labor. Relaxation techniques. So teaching them particular breathing techniques can be helpful. An active birth just means that you tell them you can move around the room, you can be on one of those bouncy balls, do lots of active things, can help them. So the reason that's helpful is because of the effect of gravity, literally, helping you to bring the baby's head down. Okay. Heat and water. So this refers to water baths. So if you go to Dandenong has a particular a birthing room. So that I haven't actually seen it being used, but it should be helpful. I mean, when you're in a warm environment, you always feel relaxed. I mean, when you have a warm shower after a long day, it always feels good, releases endorphins and such. And then touch and massage refers to getting your partner to massage you in particular locations to try and decrease your anxiety and stress during labor. And when you do that, you have to tell them this is something that you should practice before you actually get into the room. Okay. All right. So first one was natural. And then this one is things that we give them but are not medical. So the TENS machine. So remember, this is something you can get over the counter at your chemist. It's like $30 or $50 to rent out or something like that. So it's a small, so you wear it on your body, portable, battery operated, attached by pads, and it provides small electrical currents. So what that's thought to do is sort of like the gate theory of pain, try and distract you, try and release some of those endorphins and trying to remove some of those pain symptoms. Okay. And then water injections. Okay. So water injections, unlike what a lot of us might have misconceptions, I know I did until I read about it. So the way water injections are done is you get sterile water and you inject it subcutaneously into 4 locations on their back. So the reason we use water injections is usually for women who are having lower back pain, because that is what it's purported to try and decrease, is the back pain. So into those 4 quadrants, for the first 30 minutes, it has a strong stinging sensation, so it is not pleasant at all. So 30 seconds. And then after that for a few hours, it gives you relief. I'm not sure how good the evidence actually is for water injections, but regardless, is on the Ranscott guidelines, and that's how you do it, 4 quadrants of the back. And then finally, for our medical. So I know this is a lot of information, and that's never how I do my slides, but it's just there for your reference. Because remember, this is all on the mixtape. So medical management, so nitrous oxide. So how do we give it? So it's a mouthpiece. They breathe it in during contractions. So the benefits, and in an OSCE session, you should always talk about the pros and cons of anything. So the pros would be it helps you to concentrate with your contractions. Because you're breathing in, and when your contractions actually happen, it helps you to focus during that time. You can up titrate it and you can down titrate it, and it's relatively safe. The only adverse effects, some people might have nausea and some people might feel a little bit lightheaded. Very commonly used. Okay. Now the next one is opioids. Now opioids in general are not used very commonly. Okay, but there are a few things that we need to know about it. Okay. Now the 2 most commonly used opioids are pethidine and morphine. Pethidine is not really used much these days. There's a few reasons for that. Initially, back in the historical days, pethidine was thought to have less adverse effects than morphine, which is why it was used more commonly. But these days, we've actually found that it's worse. Now, the reason for that is in the mother, pethidine will be metabolized and removed from the circuit, or I'm not 100% sure that's true, but removed, or maybe the half-life is somewhere around 2 to 3 hours, okay? But in the baby, it crosses the placenta and it goes into the baby and it stays there for up to 23 hours rather than 3 hours. And it takes much longer for it to be lost. So if you give a baby, or if you give the mother pethidine, within I think 2 or 3 hours of giving birth, you increase the risk significantly of the baby having respiratory distress syndrome, which is why that was the answer to the previous question. So if you read the guidelines, the answer to that question is directly in there. So it can cause IDS, especially if it's within the first 2 hours of birth, but it can cause a lot of other things, so acidosis, low APGAR, and difficulty feeding. Okay. The other thing is that opioid analgesia actually hasn't been shown to be as effective as other forms of analgesia. So it's not that commonly used. It's still used. So you can give an intramuscular injection of morphine, but there's other things that we would consider better rather than an opioid injection. Okay. All right. And another thing, 30 minutes to the maximal effect. So then the last thing is epidural. Okay. So epidural is injection of the anesthetic directly into the subarachnoid space. So considerations, you need to get the anesthesiast to come in. They're going to be connected to a little pole, so it's going to be harder for them to walk around. But positives, they can up titrate and down titrate the analgesia as required. Is very effective. Lots of different things. Okay, but when you're counseling a patient, there's 2 things or 3 things in particular that you must tell them if you're in an OSCE station. Number 1, you can drop your blood pressure and you can also drop the baby's blood pressure, which is why they need to have a CTG and why they also need to be on a fluid drip. First thing you need to remember. Second thing you need to remember is that it decreases urinary sensation, so they need to have an IDC in. So there's 3 things that they're connected to. They're connected to a fluid drip, they're connected to an epidural drip, and they have a catheter inserter. So there's a lot of different things that you need to know. And then the last thing is that although it's small, having an epidural increases your risk of requiring further emergency management. So things like C-section. I'm not sure exactly what the reason is. Okay? Very good. All right. Cool. Well, actually, nearly. Okay. 35-year-old. She has GDM, well controlled on diet. There are no other high risk factors. 5 centimeters dilation, spontaneous rupture of membranes, clear fluid. How should you monitor the baby? Continuous CTG, or do we do intermittent auscultation? Which one? Just put your hand up if you think this mother should have CTG. Put your hands up high, like really high. Stand up from your chairs and jump. No, you don't have to do that. Okay, put your hand up if you think it's intermittent auscultation. Ooh, you're my minority group. Okay. Now this is another adventure that I had. Okay. So trying to find what the actual answer was, and I actually thought it was CTG as well. Okay. But it turns out that it's false. Okay. So the answer is auscultation. It's very easy to find these kinds of answers. This is why I always tell you, look at the guidelines. It clearly says in the guidelines, it is not indicated when they have no other risk factors. Okay, so for a mother who has GDM, and you are very, very correct in saying a mother with GDM definitely is a consideration for having CTG. But if they're well controlled on diet and exercise alone, they do not need CTG. If they're on any kind of medication though, they do need a CTG. So this table is from RANSCOG, but the PROM guidelines directly reference this document in the PROM guidelines. So it says it here. So without complicating factors. And in the PROM guidelines, it goes on to explain that no complicating factors means well controlled on diet and exercise alone. So this was another one of my adventures, but it was a good quest. We got a reward in the end, didn't we? Okay. Is there anything else I need to mention for that? Oh, okay. So in general, what are the indications for a CTG? Remember how we broke it down into categories many weeks ago? So medical reasons, iatrogenic reasons, fetal reasons, and labor reasons. Okay, so medical, so GDM, as we've talked about, if they have preeclampsia, if they have APH, so if they have antepartum hemorrhage, so those would be medical reasons for doing a CTG. Iatrogenic, what would be an iatrogenic? So something we did to them. So what would we do to them that requires them to have a CTG? Induction or C-section. So obviously not while you're doing a C-section, but before a C-section. So any consideration for a C-section, especially an elective C-section, you should have them on the CTG monitor. Okay. What kind of? So rupture, that will come down into labor, into my labor category. Okay. So medical, iatrogenic. What kind of fetal things would require CTG? Yeah. So reduced fetal movements if they're post terms. PPROM, or I guess PPROM, yeah, PPROM would be medical, okay? Sorry, labor. So then labor, so if it's an augmented labor, we've already talked about that. If they have an epidural in, if they have any kind of PV bleed, and if they have rupture of membranes, as you talked about. So just think about these. These are ways that you can break down the indications for having a CTG. Okay, next question. Oh, we've already talked about this. So you do a CTG at SPAD, what do you do next? Fetal scalp, okay? And it is in one of the guidelines, it is 7.2.1.
Yeah.
Okay. All right. So this test reflects uterine perfusion and the physiological process of fetal swallowing, cardiac function, and renal function. Let's go through this first of all. What's biometry? So this is ultrasound. So this is measuring the things like the waist, crown rump length, and measuring the fibula length and femur length and the head circumference, abdominal, etc., etc. You get what I mean. That's what biometry refers to. Umbilical artery resistance. What's that? But what is it? What's it? What do you do it for? So this is a measurement of placental resistance. Okay, so it's a measure of the placenta. So IUGI, as you correctly said. Okay, other things. It's just a side note. Remember how we talked about a few weeks ago how nuclear translucency scan, you have to do it before 14 weeks. And remember the reason for that was after 14 weeks, placental resistance decreases and lymphatic flow increases. So therefore, after 14 weeks, nuclear translucency will no longer be present on the ultrasound. Just a side note. Okay, fetal blood sampling, we already talked about. Quartocentesis. What's the proper name for this? Percutaneous umbilical cord sampling. Okay, so that's what quartocentesis is. Why do we do it? So usually we do it to diagnose and treat blood conditions. So what kind of blood condition would we treat by going into the baby's umbilical cord? Anemia. Okay, perfect. That's very good on you. CTG, we know about ECG. Intimate also, we know about all of this. Okay, so AFI, so we'll just call this amniotic fluid index, okay, just for the moment, okay? So that falls under, let me just erase all of this. So that falls under the biophysical profile, You guys heard of that term? BPP? Have you guys heard of the word biophysical profile? So if you went on to that particular place in Monash, I forgot what it's called. MFM, FD, fetal, FD, whatever, one of those. Fetal diagnostic unit. They do. No.
Oh, it's been way more than 3 seconds.
30 second rule.
Fine.
Okay. So AFI is done as part of the fetal biophysical profile. Okay, and that and that is to score 4 discrete biophysical variables by ultrasound. Okay, so what are those 4 things that we look for? 1 is breathing, so fetal breathing. Okay, number 2 is tone. Okay, fetal tone. Number 3 is movement. Okay, and then number 4 is the amniotic fluid index. So those are the 4 things that we look for on the biophysical profile. And the amniotic fluid index is looking at 4 quadrants in the uterus to see how much amniotic fluid there is. And this question is definitely amniotic fluid volume. Next one. So 40 years old, nulliparous, 6-month history of dull pain in lower abdomen, dysmenorrhea, heavy periods. She has a mass in the midline, in the suprapubic region, firm. What do you think she has? Fibroids. Okay. She's only 40 years old. Okay. There's nothing else to indicate that she might have a cancer. Okay. And fibroids is also the most common cause of menorrhagia and dysfunctional sort of bleed. Well, not necessarily dysfunctional bleed, but menorrhagia definitely in this age group. Okay. So fibroids is probably the best answer.
How would you know it's not adenomyosis? Just commonality.
Because of a question that's going to come soon. Okay. So Miss Jones is 22, so she's young. She's nulliparous, irregular periods, non-tender, solid, mobile mass in the right adnexa. No hepatosplenomegaly or ascites. What do you think she has? Okay, first of all, is that going to be the adnexa? No. Is that going to be the adnexa? Yes, potentially. If you have endometriosis going to your ovaries, you can. Okay. A benign ovarian tumor. That is the most common cause. Actually, it's not. Is it? No, the dermoid cyst is the most common cause. Look up what the most common cause of an ovarian tumor is. Okay, it's in the Y files as well. Okay, adenomyosis, is that going to go to that next time? No. Cancer, no. Pyometra. So that's inflammation of the uterine cavity. Okay, that's also not going to be that next time unless you have, for example, lymphadenopathy. But there's nothing else in here to suggest that that's the case. So the answer here is a benign tumor. Okay. So 42, 2-year history of lower abdominal heaviness, heavy menstrual bleeding, smooth enlarged uterus, total hysterectomy was performed, and the histology confirmed glandular tissue within the myometrium. By definition, that is adenomyosis. By definition, there's nothing else you need to know. So glandular tissue, only the endometrium is glandular, as we saw in those histology pictures, is going into the myometrium, which is the definition of what adenomyosis is. Okay. So 22 years old, G1P0. Her baby has microcephaly and intracranial calcifications. And we've done this a lot. So what do you think this is? CMV? I mean, if you look at any of the other videos, I'm sure we go into more detail about it. So 35 years old, she's sexually active, presents with vaginal discharge, profuse, curdy, white, thinning and redness of the vulval skin. What do you think she has? Candida, she has thrush. With this, white discharge, okay? Curdy as well. So all classical descriptions. 30 years old, she presents with severe dysuria. What would you think about for severe dysuria just before we go on? Yeah, okay, good. Lower abdominal pain and a green, yellow, bubbly vaginal discharge that is foul smelling. What do you think she has? What would be your other differential? Gonorrhea or chlamydia, okay? So chlamydia is, well, is not necessarily going to cause this discharge, okay? Maybe. Gonorrhea might, but chlamydia especially can cause non-specific urethritis, which is, if she didn't have any of these other symptoms, would be another very reasonable differential for you to have. Okay, 99. PCOS. What should we do? So, okay. From the following, please select the most appropriate description of the clinical condition. Okay, so PCOS, do they have postcoital bleeding? No. Do they have irregular bleeding, menorrhagia, dysmenorrhea, and infertility?
Yes.
Yes, they definitely. Well, let's have a look at the list first.
I don't know.
Do they have secondary amenorrhea and FSH with more than 20? More than 20 is more associated with what? Premature ovarian failure. So they have a high FSH. Secondary amenorrhea, infertility, withdrawal bleeding after progesterone challenge test. Okay, so we've highlighted two options, D or B. Okay, dysmenorrhea, dyspareunia, and chronic pelvic pain. I think they meant amenorrhea. This one, what do you guys think this is? It could be PID. In some situations, it might be fibroids. There's many things that it could be. Raised prolactin, normal TSH, low FSH. Yes, so perma. Okay. So remember we talked about the progesterone test? Do you guys remember? No, okay. So the progesterone test, we identify the normal cycle first. We give them progesterone for 3 to 7 days, okay? What their progesterone aims to do is to mimic the normal hormonal concentrations, okay? So usually we do the progesterone test to try and identify why this woman isn't having normal periods, okay? So we give them progesterone for that amount of days. And if you remember back early in the presentation, how we talked about how progesterone slowly decreases throughout your cycle, and that is what causes you to have your period, okay? So very similarly, we give them progesterone for a few days, then we stop it, okay? If they have a withdrawal bleed after that, it indicates that it's a problem with the hormones. So PCOS, you have a problem with your hormones. So after giving the progesterone, it should resolve normally, okay? If it doesn't resolve, it's because of another reason. For example, something like premature ovarian failure would be somewhere where you would get no bleed after having the progesterone test. So how do we differentiate? So other than that being correct, how do we differentiate that from option B? What there is incorrect? Menorrhagia, okay? So normally someone with PCOS would have amenorrhea rather than menorrhagia, or they might have irregular bleeding, as that's correctly said. So that's why D is correct. Secondary amenorrhea is because they had periods to start off with when they were more than 16 years old, but now it's been more than 6 months that they have not had a period for. What is the first thing you need to exclude? Pregnancy. Okay. Yes. Okay. B. So submucosal fibroid. So the thing is that more than 5 centimeters. So again, if you look at the menorrhagia prompt guidelines, you can use a Mirena if a fibroid is less than 3 centimeters. If it's more than 5 centimeters, you can't use a Mirena. So by that, just little piece of information, you can understand that that is quite a large fibroid and it's going to cause many symptoms. Okay. In that sort of situation, you need to have surgical management, or you can use something called MGUS, which is magnetic something. So I'm not actually sure if it's used or yet or not, but it's a very modern technique. But the answer to this one is B. Okay.
Oh.
Are we actually on time? 5 minutes early even. Okay, so next week. Yeah, actually we should have activity time now. So next week I won't be here. I'll be in Brisbane, and
Why?
I'll be at a conference. So Risir has very kindly not offered. I've kind of forced him to present next week. So we'll be blessed to have him.
Okay.
So again, thank you very much for coming, and apologies again for any mistakes. I try. Thank you always for telling me your thoughts. It's always really important. And I'll see you in 2 weeks' time, I guess.
Enjoy your conference.
Thank you. Sorry? I think Risri will be doing dermatology and like GP topics, like derm, ophthal, and such.